Yeah. First off, thanks for the attendance and thanks for the invite out. I've been doing similar things out in St. Albert and Strathcona for a couple of years now. We have some residents that are coming out there as well to do presentations. And Mindy, I guess going forward, we have a few dates scheduled going forward. So if there's particular topics that you guys want covered or want me to speak to, or you have an interesting case, what happens a lot of time out in Strathcona and St. Albert is one of the medics will present a case and we'll just do a short case presentation and then have some discussion around a case. So that's been happening quite frequently in St. Albert and Strathcona, and it's a good thing. I think Strathcona is getting a sim man, and we may incorporate some, put a couple guys on the spot and incorporate a scenario or something like that during the, time that I'm with them as well at some point. So just to let you know what's going on at other places and what we're doing. Typically, out there, they've got a contract with the University of Alberta Emergency Medicine residents, and they're coming out and doing an hour presentation at a couple times a year, or 6 times a year I think at their sites. I think we're scheduled for 4 meetings out here, but I just want to make sure that you guys get out of it what you want to get out of it. And so if there's particular topics that you want me to cover or address, just let Mindy know, or I don't know who else would be involved in that decision. Or yeah. Okay, so whoever you need to contact to, and then they can let me know and I can have something prepared to do that. So a lot of you are familiar to me, a lot of the faces are familiar. Jay's coached my daughter in soccer, and I see him at ESA occasionally. And so I'll tell you a little bit about myself. I'm a practicing emergency physician at the Royal Alec primarily. I'm privileged at all the sites, but my primary clinical work is at the Alec. I do STARS call, I do trauma team leading. I'm Associate EMS Medical Director for Edmonton Zone. Prior to that, I was the Medical Director for Strathcona Fire for, I guess probably close to 10 years, maybe 9 years prior to that. Prior to that, I was the Assistant Medical Director while Jim Davidson was still there, if any of you guys remember him. So that's a while ago. I'm also one of the national examiners for the specialty of emergency medicine. So that's out in Ottawa, and that's the 5th-year residents that come out for that. And then I'm on a few other committees, and then I do a little bit of private industry work with some of the oil companies as well with their emergency response. So got lots of hats and lots of responsibilities. But personally, I'm passionate about fishing, passionate about golfing, like surfing. I just got back from Hawaii, so I'm rested and relaxed and happy. So anyways, today I think there's been a bit of confusion around longboard immobilization, and I know that they send out a memo probably end of December, I believe, to kind of clarify things a bit and to line things up, because there was quite a variance in practice of what EMS was doing when the new protocols came out with spinal motion restriction. So Mindy asked if I would address that and talk to that a bit. So I'll go through. I have a bit of a PowerPoint presentation that the medical director team from Edmonton kind of put together, and then we'll go through I'll just talk to the current revision or the memo that came out in December that you guys would have all seen, and then we may just look at I think there was a training portal on the AHS EMS website that most of you guys should have gone through, if not having completed, and we'll just go through it. So if you have any questions at any point, feel free to interrupt, or if you've got, and once we get through that, I'm allotted 2 hours. I don't know if we'll spend all that time, depending on how things go, but if you guys have other things that you want to ask about or talk to me about, feel free to do so, other than contracts and other things like that I have nothing to do with. So anyways, So we'll talk a little bit about longboard immobilization and why the change in practice and thinking around that. And then, like I said, we'll review a few of those other things. So, you know, the longboards are kind of, I mean, they serve a purpose, right? So the purpose is primarily to extricate patients, but realistically, there's a few reasons why they don't do necessarily what we want them to do, as far as in essence they cause injury in a lot of cases, right? With prolonged immobilization on a spine board. They're good extrication devices, but as soon as we can get a patient off a longboard or a hardboard, the better, right? Because the biggest issue is obviously with you know, down the road. It's not so much when we're dealing with them acutely, but if these patients are left on a spine board for a prolonged period of time, they end up with pressure sores, pressure ulcers that cause significant problems down the road, right? And they all have to be covered and flapped. So when we talk about spinal motion restriction, we're talking about application of a cervical collar and maintenance of a neutral spinal position, okay? Spinal immobilization, I mean, has come to represent application of a cervical collar and putting him on a long backboard, right? And like I said, we're more interested in spinal motion restriction as opposed to spinal immobilization, because it's kind of a misnomer anyways. So the goal of immobilization is to prevent further spinal injury, reduce pain and discomfort, and we all know that people have significant pain and discomfort just from being on a board, right? Like, you don't have to be on a hard board for very long before it's very uncomfortable. I don't know, you guys would probably have all done that sometime in your training where you are the one being strapped down and immobilized, and it's not a very comfortable thing for very long, right? And then obviously we want to prevent undue movement during extrication and transport. And the question becomes, are we even meeting these goals when we put somebody on a backboard and do all that? And there's some good evidence. I mean, all this stuff is backed up by medical literature, and that's why we've chosen to, that's why things changed in essence, right? So why do we put people in full spinal immobilization? So mechanism of injury, patient exam findings, nexus criteria, combative patients, protocols is probably the biggest one. You guys are doing it. And then evidence-based practice was pretty minimal with regards to that, right? So when do we consider immobilizing somebody, I guess, is my question to you guys. Like, what are your indications for putting somebody in spinal motion restriction? We'll just throw it out there. You can throw out the indications that we have, right? So mechanism, big one, right? So if somebody meets, you know, the criteria for mechanism, if they're ejected, what other things, what other high impact things or high jeopardy things? Yeah. So, yeah. So all those things, car versus ped, fall from heights, all those things have a high likelihood of spinal cord injury, and that's why we choose to, you know, put these people in spinal motion restriction, right? So do we prevent further spinal injury by putting people immobilized, right? So definition of instability is not standardized. Will motion make the neurologic lesion worse? And honestly, once the neurologic injury has happened, it takes a lot of force to actually injure somebody's, you know, vertebrae and break vertebrae and do all those things, right? I've got a slide a little bit later on is just showing how much force it takes. You know, neurologic lesions are dynamic. The current protocols certainly, or the previous protocols certainly favored a conservative approach. So you remember that spinal cord injury happens when you get a transfer of energy and the associated vascular structures. Like, when I think of cervical spine injuries, like, you know, we always think of the bones or the bones broken, right? But there's lots of injuries to the vessels. If you remember, the basilar arteries run right up through, or the vertebral arteries run right up through the you know, foramen in the spinal cord, right? So if you've got any kind of movement there, you can cause vertebral artery dissections and those kinds of things. So it's not always an injury to the spinal, like the bony structures of the spine. It's sometimes the vascular injuries surrounding that are injured and can cause neurologic problems, right? So, I mean, you know, there's lots of reported literature chiropractic manipulations causing a vertebral artery dissection. These people come in with cerebellar strokes, right? So, I mean, and that's from a chiropractic manipulation, right? So you're not breaking bones when you're manipulating a neck, but certainly you're altering the anatomy and the vascular structures there, right? So when we think about it, you have to remember, you know, sometimes we're immobilizing these people, and they do have, you know, we're always thinking of broken bones, but there's other structures there that can be injured, right? So, you know, like I said, the injury happens at the time of the injury. It's pretty rare that you're going to reproduce an injury or cause, you know, do anything when they're put on a stretcher, right? Because at that point, the injury has already occurred. If they've transected their spinal cord, if they've got a, you know, a burst fracture that's, you know, compressed the spinal cord or completely severed the spinal cord, the injury's done, right? Like you're not gonna affect change in that scenario. So huge amount of force to cause a fracture, right? So 2,000 to 6,000 newtons of force to fracture a vertebrae. Lumbar spine is about 4,200 newtons. So if you hang, just to give you an idea of the type of force you need, I mean, if you hang your head off the end of a stretcher, that's about 40 newtons of force, right? So you think about that, we're talking, you know, magnitudes of order more than that, right? Like hundreds of times more force required than just hanging your head off the end of a stretcher to cause fractures and cause injury. So the forces we're talking about are big, right? Having said that, I mean, you know, do we see grannies who fall from standing and have an odontoid fracture? Yeah, we do, right? So again, mechanism, those kinds of things always plays into it as well. So out of hospital, so when we're talking about blunt trauma, there was a study in the academic emergency medicine literature in 1998 that basically showed that immobilization has a little to no effect on neurologic outcomes in patients with blunt spinal cord injuries. Again, demonstrating the fact that once the injury has occurred, you're not going to affect the outcome of these people. If they present, you know, with a hemiparesis or a paraplegia, when you guys see them, you're not going to affect their outcome, you know, by moving them, transferring them, putting them on a stretcher, right? The injuries occurred at that point. So, and again, you know, another thing in this day and age, vehicle damage, as you guys know better than anybody, isn't really an indicator of you know, how bad the injury is going to be and everything else, because just the way the vehicles are engineered these days with crumple zones and, you know, the impact testing that's done, and the use of seat belts. I mean, Doug would know, and some other guys have been practicing for, you know, a long time. It's, you know, you don't see the catastrophic injuries that you used to see, I think, because of vehicle design and seat belt use, right? You know, the old days when, you know, I was a kid and we were loaded up in the back of a station wagon, not belted, and riding around, rolling around, there's probably a lot more, you know, opportunity for injury than there is now, with kids buckled in car seats and all that kind of stuff. So, and again, just to reinforce, spinal cord injuries are rare, right? Like when we're talking, like I can go months at work, and, you know, we're one of the neurosurge referral centers, us and the U. And we take a lot of spinal trauma at the ALEC. You know, it's rare. Like you'll go months without seeing somebody with a spinal cord injury, and then you'll see a rash of them, right? It's usually in the summer. It's usually like, you know, young guys being drunk and stupid and do something, or people, you know, it's an MBC or something like that. But they are rare. We're talking, you know, at the high end, 40 cases per million population, right? So in Edmonton zone, I mean, if we talk about Edmonton and the whole catchment area being, you know, 2 million, say, at the most, you know, we're seeing anywhere from 15 to, you know, 40 at the high end per year, right? So it's not a huge volume of patients, but these patients are highly resource intensive, right, if they do present with a spinal cord injury. And it's a long rehab, it's a long, you know, it's a terrible process for those patients. I mean, it's a huge rehab. It's a huge, you know, I can't imagine having that happen to me, right? Like it's got to be a difficult process for the patient to go through. Whereas when you look at the rate of brain injury, it's about 8,000 per million, right? So again, exponentially higher, right? Like we see far more intracranial bleeds, secondary to assault, all those things that you know, are far more significant in the population that we see. And then, you know, obviously half of the ones we see are secondary to motor vehicle accident, and then 25% of them are from falls. And then, like I said, and the exception to that is about 65% of the patients that we see who are elderly, like over age 65, then their major mechanism is generally falls. So why do we immobilize awake, alert patients who are not complaining of neck pain or any other focal neurologic deficits? You guys know? Why do we do it? Protocol, right? Some of it's based on mechanism though, right? Like, I mean, you know, if they have a high mechanism of injury or if they've got other distracting injuries, then certainly we do, right? I mean, all of you guys have seen, or if they've got, you know, if they're intoxicated for some reason, that's another big one, right? I mean, I remember there was a case in Edmonton Zone shortly after I started where intoxicated patient was found at the bottom of a set of stairs. They had no whatever, like, you know, obviously he got to the bottom of the stairs somehow. Somebody didn't think that he could have fallen, and they walked him out of there, and then lo and behold, he gets to the hospital, and nowhere is it told to anyone that, you know, how this guy got there and wherever, and thrashing around through the night and ends up giving himself like he had an unstable spinal injury and ended up quadriplegic from it, right? So mechanism is a big one that you can't forget and think about, and especially if patients are intoxicated and or have other distracting injuries, you probably should immobilize those people, right? It's not, I guess, you know, whenever I think of, you know, EMS, your role is sometimes to you know, sometimes if you think too much, it's not a good thing, right? Like sometimes it's better to just, okay, we found this guy at the bottom of the stairs, we don't know how he got there, we'll put him in a collar, we'll mobilize him, we'll extricate him and get him out there, right? Because honestly, like for us, you know, if that patient presents in a collar, it's on our radar and we say, okay, you know, if nothing else, we'll leave him in the collar and assess him when he's sober, right? And see if he's got any tenderness. It's no big deal for me to leave a patient in a hard collar and immobilize him. I won't always image all those patients. I mean, just because you put them in a collar doesn't mean that we're going to image every patient. But certainly it puts it on, you know, the radar of the physician that's treating the patient, that, you know, that's a possibility that this guy could, just based on mechanism or how he was found or whatever, that could be an issue, right? So, you know, again, just because you guys put a collar on doesn't always dictate what we do, but it certainly helps us, you know, kind of make some decisions as far as, okay, we'll let this guy sober up and make sure that he does truly not have any neck pain or anything else like that, right? And certainly for nursing, it helps as well, because then they're going to be, you know, mindful of the fact this guy's got a potential spinal injury as well, okay? So penetrating trauma, this is probably one of the biggest ones. There's no evidence to support immobilization for patients with penetrating trauma. If somebody gets stabbed in the neck, their biggest issue is going to be, you know, vascular structures, injuries, you know, that, you know, airway issues is probably going to be one of the biggest things, right? So if we put people in collars who've got penetrating injuries to the neck, number one, you'll hide hematomas, it just obviously it makes it more difficult to intubate patients if they're in a collar, those kinds of things, right? So there's basically no evidence to support putting patients in spinal immobilization with penetrating trauma. If they've got an injury that, you know, caused a spinal cord injury from a penetrating wound to the neck, and I've seen that happen. You know, they're gonna present with deficits immediately, and obviously those patients we're gonna collar. But if they present with no deficits and everything else, then, you know, there's no evidence that you're gonna do it. And again, they're not gonna have it's going to, if it's a penetrating injury to the neck, they're not, unless it's a gunshot wound, they're not going to have unstable fragments of bone, right? They're going to have like basically a knife into the spinal cord and out, right? So it's going to be more an issue of they've transected their spinal cord. It's a done issue. They aren't really an unstable C-spine, if you get what I'm saying. So putting them in a collar isn't necessarily going to, you know, affect management. It's just going to make management difficult. And again, you know, it's in a lot of ways it's going to affect mortality because it's going to delay resuscitation if you're fiddling around with the collar and everything else. And again, there's an article in 2010 in the Journal of Trauma just saying that, you know, it causes more harm than good to actually immobilize these people. And then the other one is indirect spinal cord injury doesn't happen to patients with gunshot wounds to the head, right? So, I mean, that was one thinking that, you know, get shot to the head, their head's going to snap and they're going to, you know, cause a spinal cord injury. That doesn't happen. So, you know, somebody has a gunshot wound to the head, don't waste your time with immobilizing patients. Just get them to the hospital. They need to be, you're far more concerned with those patients as far as, you know, not causing an anoxic brain injury, you know, as opposed to worrying about collaring them and doing all that stuff. So, okay. And again, you know, obviously when you have a patient in a hard collar, it makes it far more difficult to capture the airway, right? Like you guys, you know, a number of you have been practicing medics for a long time. You know that it's far more difficult to intubate a patient in spinal precautions, right? I mean, it's more difficult at the hospital, and we have far more help and hands than you guys do on calls than we do a lot of times, right? So we have, you know, we've got other agents and tools that we can use as well, right? Like we use a lot of indirect laryngoscopy with, you know, the glidoscope and other tools that we can use to minimize manipulation and that kind of stuff. And, you know, I know St. Albert has purchased the video laryngoscopes and stuff like that, but still, I mean, it's still the same action as the thing. It's just that you have a visual view, whereas, you know, the glidoscope is more, it's less of this and more of just manipulating the epiglottis actually, or just in the vallecula, you're just giving a little twist and tug. So we manipulate those patients very minimally with the glidoscope, right? So, you know, it's often difficult to do it with direct laryngoscopy to get a good look, especially when they're in a collar. So I guess the underlying statements is if they've got penetrating neck injuries, don't bother with hard collar. You know, that's probably a change, that was a change in practice, I think, for a lot of people and a lot of your teaching from paramedicine, right? Any trauma, you were collaring these people, but honestly, penetrating trauma is we don't collar those people, or if they come in a collar, I take it off because it just makes things more difficult. We want to see what the injury is. We want to see if the hematoma is expanding, those kinds of things, right? And there's evidence to show that it increases mortality. No benefit if they've got a gunshot wound to the torso, even in the presence of unstable spine fractures. So they're twice as likely to die as an immobilized patient. That's from Journal of Trauma as well, 2010. So essentially any penetrating trauma, even if they have a unstable spine fracture, immobilizing them isn't going to change the outcome, right? Because if they've taken a blast to their spinal cord, it's not immobilizing them isn't going to make a difference, right? So again, we talked about failed airway. It's the second leading error that proceeds to death in trauma patients. Spinal immobilization impairs the capture of the airway, and you know, it's obviously difficult if they're vomiting or if they have airway bleeding, if they're restrained, right? So it impairs your ability to capture the airway. So then we'll talk a little bit about spinal immobilization. Don't think it means what it think it means. So, you know, I don't know how many of you guys have seen patients in halos, right? But even halos, we think, you know, that's a pretty good fixation on the head, right? So I remember when I was when I was a resident, rotating through neurosurgery and, you know, screwing these bolts into people's heads, right? And you know, that thing is, once that thing is screwed on, the actual the ring that goes on to around their forehead, that's in there pretty good, right? And it's, you can, you know, basically grab them. It's like grabbing somebody by the horns, right? But even putting them in that device, it's you know, there's a significant amount of movement. There's 4% of motion still in a halo, right? And that's something that we use to immobilize spines, right? So, you know, if you think you're actually immobilizing somebody by putting them on a hard board and collaring them, there's obviously a significant amount of movement that's still allowed, right? So, you know, obviously, if you immobilize and then if you move around the trunk quite a bit, you're obviously going to get a significant amount of movement in the neck. And you know, I guess the biggest example you used to see of this is patients on spine boards, and the thought was, well, if they're vomiting, we can just roll them on their side on the spine board. And you know, I don't know how many times I saw that occur, where the patient's head is fixed, taped down, the body slides, and all of a sudden you've got this huge distraction from the torso to the neck, and you're like, okay, have we really done this guy any favors, right? Like, probably not, right? So, I mean, that's, you know, that was kind of one of those things that was out there that, well, if they're immobilized, we can just, you know, it's easy to, you know, flip them on their side and roll them. And I guess, you know, the current thinking now is, well, if the patient's vomiting and doing that, you're probably better off to actually position them and like immobilize them or spinal motion restrict them on their side, as opposed to, you know, trying to lay them flat. Or if they are vomiting, you know, obviously you need to roll them and not just flip the board, right? So, and to roll them, how many people does it take to roll a person adequately, right? It's usually about 4 people, right? So somebody controlling, you know, controlling the head, and then 3 other guys to help you roll the body. So it's fairly labor intense to do that, right? So sometimes you have to recruit other people to help you and do it, whether it be nursing if you're at the hospital, or, you know, some of your other colleagues if you're, you know, on a scene, and, you know, your fire colleagues are extricating the patient and you're on EMS, then you should be recruiting them to help you, you know, roll these people if need be. So we talked about this already, but one argument is to mobilize on a longboard is that only one paramedic can roll the board by themselves without significant movement. And I think you guys all know that's not the case, or you've probably witnessed it not to be the case in many cases, because they get a significant shift in body weight, and it actually causes more movement in the spine than mobilization was you know, there to prevent, right? So there's no evidence to show that pre-hospital immobilization actually reduces the incidence of neurologic decompensation, right? So, like I said, once the injury has happened, it's happened, right? So the question is, are we actually causing harm by doing this? And the answer is probably yes, right? So it's not a very good image. Allison put this together, but it just shows you this huge lesion on this guy's sacrum and buttock area there. That's a big pressure sore, right? That's from laying on a spine board for a prolonged period of time. And again, you guys probably don't appreciate that, because, you know, you'll see it if you take somebody off the board, you'll just see a big area of redness or whatever, or, you know, you'll look at it and you go, oh, that doesn't look, you know, good, or it looks like it's a bit sore, right? But those things progress and develop into pressure ulcer. That's why these patients are so intensive in hospital, because they constantly have to be moved and rolled. Fortunately, now there's beds that, you know, inflatable beds that inflate, deflate, and kind of do the work of, you know, that what used to be a lot of manual labor in managing these patients. But previously, I mean, obviously very labor intensive on the ward with these patients once they do have a documented spinal cord injury, of preventing, you know, further pressure sores and those kinds of things. And again, another reason is, I mean, this, again, not a terribly clear image, but just showing you the normal kind of cervical lordosis, thoracic kyphosis, lumbar lordosis again. So your body, your spinal cord isn't straight, right? Like, I mean, it's got some curves and bends in it. So laying them on a hard, flat board is not ideal, right? I mean, everybody's seen, you know, these grannies that, I had this lady about 2 weeks ago, or longer than that, I guess, because I've been away, but she walked around like this the whole time in the hospital. Like, she couldn't even straighten up. Her back was like the hunchback. And I looked at her and I was like, she'd be a good one to try and spinal board, right? It'd be impossible, right? Like, there's no way you'd be able to even get this patient to lay flat. She'd be so short of breath and problematic to do that with, right? So again, I mean, it's a good extrication device. It serves a purpose, but as soon as the sooner we can get a patient off a spine board, the better, right? So this speaks a little bit to, you know, if you put somebody on a spine board, like healthy patients, how long does it take for them to you know, be in significant discomfort, right? So they were on for 30 minutes, right? Which is, I mean, that would probably be the minimum time that you guys would be transporting a patient, right? So 100% developed pain, 55% rated the pain as severe. So just the discomfort from that alone is huge, right? So, you know, I always talk about distracting injuries, right? At some point, you know, if you're on a board for that period of time, the pain is actually almost unbearable. Like, I've never personally been on a backboard, but I've heard, you know, just anecdotally from, you know, medics who have, you know, done it in their training, and they say it's awful, right? Like, it's not a very comfortable thing at all, right? And really, you know, if the goal is spinal motion restriction, you know, we can accomplish that without a hard board, right? So, this one was just showing about tissue ischemia. It's another study that was in the emergency medicine literature. So they were laying on different support surfaces, had pressure recording meters. Traditional spine boards had 233 millimeters of mercury at the sacrum, 82 millimeters of mercury at the thorax, and at that pressure, with just 70 millimeters of mercury, you can get low-grade pressure ulcers that appear within 2 hours of continuous exposure to that, right? So, you know, obviously that's not ideal, right? So, I mean, it behooves us to get them off. So in Edmonton, you know, we've got 350 patients a year that are transported via fixed wing. Flight time alone is 90 minutes at the minimum from high level, right? So you add ground transport times now from the international into that. So a lot of these patients show up, and they've been on a longboard for, I remember there was one I saw not that long ago, you know, prior to all this changing in the province, but been on a longboard for almost 8 hours, right? By the time of all the transfers and everything else, and, you know, waiting at the hospital entrance because they weren't otherwise, you know, they're otherwise stable, so they're waiting for a room and this and that. So 8 hours on a longboard, and that patient was in agony, right? And ends up with you know, that patient ends up with a pressure sore, and that ends up, you know, he may have no other injuries, but he's going to end up with a big flap from that they're going to have to, you know, bring from his buttock up or somewhere to get coverage to cover that pressure sore, right? So it's not a small deal to deal with these pressure sores. The plastic surgeons in Edmonton, it's the bane of their existence, right? Like, I mean, it's their probably most hated thing is doing coverage of all these pressure ulcers, right? That they see, you know, and a lot of them could have been prevented, right? So, you know, another issue is obviously respiratory compromise. So if you're on a spine board, it results in 15 to 20% reduction in your respiratory capacity, just even in a healthy person, right? So if you can imagine, if you got an underlying lung disease like COPD or something like that, where you're already compromised, put those patients on a longboard supine, they're going to be in significant trouble, and it won't be from their, you know, isolated rib fracture. It's going to be because they're, you know, that's going to contribute to it, but they're going to be, you know, certainly compromised from a respiratory standpoint. So obviously, like I said, you know, it's worse in patients with a restrictive lung disease, patients who are morbidly obese, elderly patients, right? So patients who have, you know, abnormal spinal morphology or whatever. pregnant patients, children, and pulmonary injuries as well. What about C-collars? $500 reward for the return of my neck, no questions asked. Brock Lesnar there. So, cervical collars can certainly result in an abnormal distraction within the upper cervical spine in the presence of severe injury if they're not fitted properly, is probably the biggest reason, right? Like, I mean, we all know that there's settings there, and sometimes people don't fit a collar even on the no-neck zone, right? So in those patients, if you've got somebody who's got a really squat build, sometimes the best thing you can do is to just immobilize their head without a collar, right? And just keep them, in a position, especially if they're alert and awake and cooperative and not bobbing and weaving around there, then, just putting, rolls and having them lay still is probably the best thing you can do. This is just an image that showed the amount of distraction in this lady who had basically a transverse, like a chance fracture through her cervical spine. And the amount of distraction that was caused by putting her in an ill-fitting collar, right? So, generally we try and manage patients. Spinal mobilization is collar plus, head rolls in a neutral position, right? That's what we're talking about. And, sometimes, cervical collar isn't always ideal to put people in. You guys have all seen patients like that or have dealt with patients like that. So C-collars must fit properly, can worsen a severe injury, should be used in selected patients. And again, remember that spinal motion restriction is not the same as spinal immobilization, right? So in a lot of places in Australia, in Europe, they'll actually manage the patients, that's their spinal motion restriction, right? They'll actually lay them on their side and roll them from there. If they're with a pillow under their head and then basically a moldable stretcher and just in alignment, right? So, there's more than one way to skin a cat. Just because, in Canada and Alberta, we've always managed these patients supine. There's other ways to manage it. The issue with these patients becomes in hospital, like to image patients, we need them supine, right? Quite honestly, like, when we're scanning these patients, we can't have them in every, contorted position possible, right? So, that was one of the biggest reasons why the feedback came, because, initially when the new protocols were being instituted, patients were being brought in every, if they didn't have any back pain, they were being brought in a collar or walked in a collar, sitting bolt upright and this kind of stuff, right? And, the nurses were absolutely freaking out, right? Because, number one, it was a change in practice. Number two, it's like you can't nurse a patient who's like in that, if you're concerned about a spinal cord injury, we still have to roll them and do all those things, right? So I think that's the biggest reason why the memo came out saying spinal immobilization means, or spinal motion restriction means collar on, supine with head rolls, right? Because initially when did the protocol change? This fall sometime, I think, is when it kind of basically came out that, there's a change in practice, and patients were coming in everywhere, from everywhere with all different types of, interpretations of what this meant, right? And quite honestly, like in the hospital world, like to image these patients, to do everything, they all need to be supine and flat, right? We can't image patients C-spines standing up and these kinds of things. They're all going to be flat eventually, unless they're, have some reason why they can't be flat, right? So if they've got significant respiratory compromise, that's the biggest issue, that we don't do that. So what are our goals? So we want to reduce gross movement. We want to prevent duplicating damaging mechanism to the spine. We want to regularly reassess, and we want to reduce the risk of negative effects of traditional immobilization. So what are indications for actually immobilizing patients, right? So, obviously if they've got a focal neurologic deficit, that's kind of a no-brainer. I think most people go, okay, probably injured your spinal cord, right? Like, you don't have to be medically trained, I don't think, to figure that out, right? But, certainly we talked about this already, like, so what are the high-risk patients that we talk about? So ejected, high impact from a motorcycle crash, auto pedestrian or bike, axial load to the head, like a diving injury or a rollover where they get a crush to the head, a fall greater than 3 times the patient's height, and then obviously patients who have an altered LOC, clinically intoxicated or high, they've got a significant distracting injury, or if they're unable to communicate, right? So those are kind of loosely, and I think there's more in that are listed in your guys's. I just reviewed it before I came, so I kind of have an idea of what was on the website there. So what are our methods of doing it? So I mean, like we talked about, and there was an image there earlier about, it can be lateral, it can be Fowlers, semi-Fowlers with C-collar only if needed, okay? It could be soft collar, it could be pillows, it could be vacuum splints or mattresses, it could be a car seat, it could be a KED, it could be a backboard with head immobilizations and straps, right? So there's all these combinations of things that we can do, but ultimately, like I said, to manage these patients and nurse these patients, and I think the new memo that came out for you guys at the end of December there, these patients, if your index of suspicion is high and you've immobilized or put them in spinal motion restriction, if ideally they should be supine with head rolls with the C-collar on, unless there's a contraindication of that. So if they've got significant respiratory compromise, and it's going to be a rare event, right? Or if they've got a bad facial smash that they're not managing their airway, if you lay them supine, if they're like coughing and sputtering. So I guess if the jeopardy of your ABCs outweighs, spinal motion restriction in a traditional sense, then obviously we'd want you to, do the right thing. So it's a bit of common sense and a bit of thinking through things. There was a case that kind of prompted all this out in Stony Plain, Spruce Grove area, where a patient was in hospital, had been seen in the Westview Hospital as a trauma. Patient was a COPDer, had plain films already out in Westview at the Stony Plain Hospital, which didn't demonstrate any cervical spine injury, but had a mechanism, like a fairly significant MVC. Patient was a bad COPDer. EMS rolls in, the patient's got a hard collar on, and the doc out there says, we can't lay her flat, she desats, whatever, right? So EMS says, no, we got to put her on a board, call her, so they laid her flat on a board, even though we know she's got she'd had plain films which didn't show any spinal injury per se. They lay the patient flat, and of course they arrest en route to hospital because they couldn't breathe, right? So that was kind of the last straw, I guess, for the EMS medical director saying, like, what are we doing here if it's that dogmatic that every patient who has or that we're trying to spinal motion restrict, if we're causing more harm than good by putting these people flat and it's obviously killing some people, we better rethink these things, right? So that was probably the biggest reason why is big impetus as to why things changed. So again, looking at spinal motion restriction, like in a lady like this, it's obviously going to be very difficult. Like, how are you going to lay that lady flat on a board? You're not going to be able to do it, right? So again, put her in a collar or lay her semi-Fowler, say, what, we've got a high index suspicion that you could have a spinal cord injury. Can you lay flat? Yes, I can. And it's like, okay, well, or no, I can't. Then, then put her in a position of comfort, make sure she doesn't move. And then when you get to the hospital, say, this is the issue. This is why we didn't do it, right? I think in general, nurses are reasonable people. I know there's a lot of head-butting between EMS and nursing. No, I know, because I don't always see it because we're not at triage, right? So we don't always see the interaction between nursing and EMS, right? But I know there's a lot of head-butting, especially over this issue, and especially when it first came out. And I think now that things have been clarified, I think it's less so. But I think if you tell them, well, we can't lay her flat for this reason, they're going to say okay, and they'll probably talk to one of the docs and say, what should we do, kind of thing. But at least it's on their radar, and we can get involved and kind of help make some decisions, right? So again, it's I can speak for the docs at the ALEC, right? Because I know all the guys I work with. I mean, most of us have a pretty heavy involvement in pre-hospital medicine, like a number of the STARS flight docs, a number of the zone medical directors, a number of the provincial medical directors for air ambulance and stuff work at the ALEC, right? So we've got a pretty good interaction with medics in general, like we all kind of get it. So I mean, if you approach, I can only, like I say, I can only speak for my colleagues, but if you approach us with a problem or an issue, or find one of us, if you're if you leave it in the care of your partner and then track one of us down, we're more than happy to answer questions and give you guys some assistance or some direction, or help sort things out with the nurses, right? So sometimes we can liaise a bit. So if there's something that you don't agree with or whatever is getting into big battle with triage, find one of the docs and talk to them and see if they can kind of mediate things and negotiate and sort it out. Because ultimately, whenever I think about it, I find that kind of ridiculous, right? Because ultimately, what's everybody's job? We're there to look after patients, right? And we all want to do the best thing for patients. So when it becomes a, kind of a pissing match, or whatever you want to call it, I guess I shouldn't speak so coarsely, but when it becomes like a battle of wills at triage about who's right and who's wrong, maybe get one of the docs involved to kind of mediate it a bit and help with things. Yeah.
You're talking about putting a collar on a patient that kind of body.
Yeah, it'd be very difficult, right? Yeah.
It causes pressure sources with collars.
Yeah.
And then they end up with chronic tissue.
Yeah.
And
Yeah, I mean, honestly, I mean, a fall like that, a lady with fall from height like that, if she had fallen or whatever, you're probably best to just manage her in position of comfort, right? And just let her manage her own neck, right? Like, I mean, most people, it's quite funny actually, because sometimes we'll get these drunk guys, right? And they'll be in a hard call or whatever. They'll be intoxicated, and you won't really pay much attention to it. And they will literally, you'll kind of start paying attention, because when they get up or when they start sober, they're like totally splinting, right? Like, people will manage, like with muscular spasm, they'll manage their C-spine to a great degree, right? Because they're not going to let their head flop around if they've got pain, right? They'll actually go into a little bit of torticollis and kind of they'll be in, like, if they have pain, they'll actually manage their C-spine themselves. So again, we talked a little bit about this lateral trauma position. It may be better for awake patients with vomiting or facial trauma. So I mean, that would be a reason. If you presented a patient like that who had a facial smash or a bunch of nasal bleeding or something like that from nasal trauma, but a fairly significant mechanism that you wanted to immobilize them, that would be acceptable, right? Recognizing that ultimately probably that patient's going to be put supine. But for transport, if all you're looking to do is manage their C-spine, and you manage them like that. But I mean, if you brought a patient in like that, I would certainly get a physician involved immediately and say, listen, this is the way we brought her in for this reason, just so that you don't get any flack and feedback, right? Because if you say that, if you can justify to me why we're bringing a patient in that position, I've got your back, and I'll say, okay, let's find a spot for this patient. We need to sort this out, right? Because I mean, sometimes if they've got significant facial smash or something like that, and we're going to need to image them and do all those things, then we're probably going to end up intubating that patient, or they may even go to the OR, right? If they've got a bad facial smash, potential airway compromise, that patient may just go directly to the OR and be dealt with there. So who will we still backboard? So obviously, if they're intubated or altered, combative patients who can't communicate, right? So if you've got patients that aren't cooperative with, spinal immobilization or spinal motion restriction, I keep misspeaking, but, if you don't have a cooperative patient, which in general is a lot of these patients, you're probably still going to put them on the hard board, right? What if they have a known spinal cord injury? So just because they have a known spinal cord injury doesn't mean they don't necessarily need backboard immobilization, right? Those patients need to have their C-spine and their T&L spine managed with log rolling and everything else like that. But hardboard immobilization isn't the answer. If they're cooperative, then supine, collar on with you know, log rolling and those kinds of things on a stretcher is fine, right? You're actually gonna do better for them if you do that, right? So if they're awake, alert, cooperative, they need spinal motion restriction, not immobilization. And these are the guys, obviously, that are at the risk for, you know, tissue breakdown. They're the guys that are going to be, you know, immobilized for a long time until they start, you know, until they have their spine basically, you know, fixed either with rods or grafts or, you know, some kind of surgical fixation, right? So what are our goals? So judicious use of spinal motion restriction. We'll mobilize only when appropriate and reduce the unnecessary use of long boards. So if you excuse me for a sec, I'll just find the other. Any questions about that or thoughts on that at all? Any comments? Unclear about anything or?
Are you still wanting, if we're just doing the motion restriction on our stretchers, do you still want the spider straps and rocks down on the stretcher itself? Or is just the basic stretcher straps acceptable?
Say again, sorry?
So when we just mobily restrict them
Yeah.
on the stretcher,
Right.
are you wanting the longboard spinal spider straps put onto them, strapped onto?
No, I mean, I guess it would be, you know, if you're transporting them, like having rolled them onto your stretcher or whatever, with the collar on, you know, head rolls, you know, I would, as long as they're alert, awake, and cooperative and can, you know, cooperate. I mean, whatever you would do normally to transport a patient, like to, because I mean, I'm sure you don't have patients flopping around in the back of the ambulance, right? So, I mean, whatever seat belting mechanism you use, but I don't think the spider straps would give you any more ability to do that, right? It actually it may even impair you if you needed to roll that patient quickly, right? So, because it's not the standard way you guys would set it up if you put those on your stretcher. I mean, correct me if I'm wrong, but I don't think those spider straps would go onto a stretcher very easily, would they? Or probably not. Okay.
It's interesting that one study you talked about there from 94. I don't remember that study or not. The 30 university students. There's about a half dozen more of those students end up in long-term vascular injuries even months later from being 30 minutes on board. Is that same one?
It could be. I don't know. I can't remember what the reference was. I don't know if this will pull up here. There we go. Okay.
It's been about an hour. Do you guys want to take a 2-minute break? Or you guys get to keep going, or we can get coffee?
You okay with that, Dr. Farr, or-
Yeah, you guys can take a break. That's fine. It's your time, so I don't. I'm good with that. Okay. Keep going.
No, anybody. I'm good. I'm little nap. I'm good.
Okay, so this is the memo that came out on December 23rd, which kind of reiterates the stuff. So it came out from Phelps and Canham, who are the, you know, the head provincial guys, right? So, so they wanted to clarify, right? So I'll just pull it down here. You guys can read it as fast as I can, but basically to reiterate that spinal motion required in all patients with potential spinal injuries, okay? The longboard isn't the answer though. I mean, just basically what I said, right? So it's contraindicated in patients who have a long transport or wait times, right? So greater than 30 minutes. So a lot of these patients will meet, I mean, if you guys are transporting these patients, they're gonna meet those criteria, right? So if you've used a longboard to extricate or move a patient, you can remove the patient from the longboard and place them supine with a C-collar and head rolls, blocks onto an EMS stretcher, secured with stretcher seat belts as soon as deemed safe and practical to do so, right? So, I mean, if you get to hospital and you've got somebody who's, you know, that you've collared and spinal motion restricted and you know that it's going to be, you know, a long time before they even get a bed or whatever, it's completely appropriate to roll that patient off the longboard, roll them back onto your stretcher, remove the longboard. leave the collar on, head blocks, and just manage them like that, right? So I guess that's the biggest take-home message from all this, and then it goes on to say, so in rare cases when life-threatening respiratory compromise may occur, if you put them in the supine position, so again they outline what they are, so head, facial neck trauma, severe respiratory disease, body habitus, they can be transported in the stretcher in semi-Fowlers or high Fowlers, maintaining spinal motion restriction with a C-collar, with head rolls, head blocks, and secured with stretcher seat belts, right? So those are the patients that you're concerned that if you lay them supine, they're going to have respiratory compromise, respiratory arrest, then those ones are the appropriate ones to come in Fowler's position, right? And honestly, if those patients come in like that and they're you know, in that much distress to lay them supine, like I said, and they've got a significant mechanism of injury, those patients are going to get imaged, right? So then the decision becomes to us, like, okay, well, if they can't manage supine, then we have to manage their breathing for them, right? So those are the patients that will get intubated in hospital in a controlled setting, and then we'll make a decision of how we're going to, you know, go forward. Obviously, if they've bought a tube for that, a lot of those patients are very difficult to get off a ventilator. So we don't make that decision lightly, but if the mechanisms there are concerned that they have other injuries and they need to go through the scanner, then we can't put them through the scanner sitting up, right? So we've got to make a decision of what to do for them. So again, this clarifies what was going on. Like, they shouldn't be transferred, you know, with the collar on, in a wheelchair or walking. I mean, you know, I think you see patients like, you know, patients are sometimes managed in hospital, like we'll manage them AAT in a collar. If we can't, you know, sometimes they'll need to rule out ligamentous injuries. We'll do flexion, extension views, those kinds of stuff. But, you know, so if patients don't have a bone injury but still have neck pain, those kinds of things, and we think that they may have a ligamentous injury, those are the patients in hospital you'll see with AAT in a collar. Or they'll be sent home in a Philadelphia collar. So one of those fitted collars that basically kind of cups the chin, and those are the patients that get those, right? But in general, you know, in an EMS scenario, it's if you're putting somebody in spinal motion restriction, it means supine with a collar and head rolls. So, and then just clarifying, you know, if they're ambulatory at the scene but require spinal motion restriction, secondary mechanism, intoxication, all those things we talked about, then again, you know, you guys do what you do normally, right? Like you guys, I mean, I've been on scene a few times driving by accidents, and immediately head's controlled. You guys put the collar on, and then you know, extricate them with a KED or whatever you do, and get them on the backboard, right? You know, obviously scoop stretchers are a reasonable alternative.
Have you done any studies on the scoop stretcher?
You know what? I don't know. I can't speak to that intelligently. So, and then obviously we use a lot of slider boards. What happens in hospital? The biggest fault in our facility is patients will get left on slider boards forever, and they're no less hard than a hard board, right? So, you know, that's been a change in nursing practice, right? Because for them, you know, they'll just leave a patient on a slider board because then they don't have to continually roll and roll off, right? Whereas, you know, ideally, as soon as their move is completed, they should be rolled off the slider and put on the bed, right? So that's the next battle that's happening, or it's happening. So, and like I said, I mean, the frequently asked questions, you know, and then obviously this piece here about the documentation from your guys' point of view and how to do log rolls, right? So, you know, you have to have somebody that's managing the head, and then you have somebody log roll the person, and somebody required to move along. So at the minimum, it's a 3-person, 4-person process, right, to do it properly, right? And then, you know, you manage them appropriately from there, and obviously document your neuro exam before and after, right? And make sure it's documented. And I reviewed the thing on the AHS website or whatever, and I'm sure all you guys have gone through that at some point recently, and so it's kind of a So again, some of the frequently asked questions, does it change how we extricate patients? No. They're extricated and immobilized, as done previously. Should I remove the patient from the longboard as soon as possible? When it's safe and practical, yes. If it's short transport times, then you may want to just do it in hospital when you move them to the hospital stretcher. Or if it's going to be a prolonged period in time, then you may want to do it there. Is there age restriction? No. If they're cooperative and able to answer your questions and do things, then they can come off. If they're ambulatory, still require spinal motion restriction. Can I walk my patient to the ambulance? No. It's you do what you normally would do, right? So if they need spinal motion if you deem that they need spinal motion restriction, then you manage them as such, okay? And do they need to remain supine while in spinal motion restriction? Not always, right? So we answered that question. But it's pretty rare that you're going to have somebody that's in severe respiratory distress or have that position. And if you ever were in the position where you had somebody supine and all of a sudden they become profoundly short of breath and have difficulty breathing, then obviously ABCs trumps spinal motion restriction, right? So you're going to do what you need to do. And generally you're going to get some more idea from comorbidities whether or not this patient has potential to go that way, right? So if they've got severe restrictive lung disease or something like that, a bad COPD, or that, if they lay supine, they're immediately short of breath, then probably not a good idea, right? But remember, some patients are short of breath because they've got a pneumothorax or these other things, right? So you always got to think, appropriately, right? So if somebody's, a young, otherwise healthy guy is supine on the spine board and is short of breath, my first thought is not, he's got underlying lung disease. My first thought is he's got a pneumothorax or a reason why he can't breathe, right? So my first thought is to, decompress the chest as opposed to, be worrying about manipulating his position on the spine board. And then obviously, I think you guys on the EPCR? Are you still handwritten PCRs, right? So, I think I would gather the EPCR is going to be coming here because Strathcona is piloting the new. Strathcona is piloting the new one. I know right now they're the first on the new system or something, so they're kind of working out all the bugs. So I think it's going to be a provincial-wide EPCR. Okay, so that's it for that. Any questions or comments, or kind of beat a dead horse here? I think you guys all kind of get it. So.
Are you able to pull up the HS protocols? Can we just kind of go over that?
I can. I had it up earlier. I can pull it up. I just have to get out of this screen so that my screen appears normally on my laptop, and then I'll get them up. It might take me a minute. If you guys want to take a break, I can pull those up, and then why don't you take a 5-minute break and then 10-minute break.
All this stuff out, I'm going to sign